At some initial level, it seems there is a natural tension between the science of mental illness and traditional religious beliefs. A natural tension. Yet if one takes their time and is honest and looks closely and is open-minded, they can see that scientific understanding and spiritual beliefs actually can go hand in hand to produce the best care for those who are mentally ill. The best care. Clergy and faith communities actually have many virtues, many advantages over mental health care providers. Clergy and churches are very, very supportive, even loving. Mental health care providers, not really allowed to be loving. We have to maintain a professional distance. Churches and clergy they lack stigma. They accept patients to come into the church. Come in all the time. You're welcome to come in. You're completely open. There's an open door policy. Anytime you want to come in, come in. To see me, you need an appointment. And you have a lot of paperwork you got to do. Churches and clergy are family friendly. Bring your family, y'all. Come on. Everybody come on into the church. You're all welcome to come in. We have HIPAA regulations. We can't talk to you without your permission, your written permission. Churches and clergy are charitable. They're giving. They're kind. They give money. They have an open pantry. They're financially more accessible. To see us, co-payments. Even though there are differences, it is very evident that we really actually share the same motives, and that is to reduce distress and to create well-being and peace in human lives. Speaking as a psychiatrist, from a psychiatrist's view, my diagnostic perspective is unrelated to anybody's religious beliefs. It doesn't make a difference if you believe in religion. It maybe doesn't even make a difference if you believe in God. My diagnostic perspective is based upon kind of a different manual or a different Bible called the Diagnostic Statistical Manual. It is based upon a number of symptoms that if you meet those symptoms, you then meet a diagnostic criteria. And if you meet that diagnostic criteria, then there are certain specific treatments that have been studied for decades and decades that are appropriate for that particular diagnosis. So my diagnoses and treatments in my office is unrelated to your religion, and it's indistinguishable, not related to your religion. But after saying all that, there are many, many places where spiritual nourishment reduces symptoms, where it relieves people. Many, many places that clergy can go that I, as a provider, a mental health care provider, really can't go. The best way to understand that is perhaps a little bit in the film that you just saw this morning. It is with a simple analogy that you should think of people as a car, a vehicle, traveling down the road of life, going to a certain specific destination, going at varying speeds, but they're all going at a certain destination. And yes, all cars have weaknesses and susceptibilities. People with a mental illness, however, at some point in their life get tossed off the road. A psychosocial stressor occurs, a storm, a tree falls, something happens that kicks them off the road. They're off the road and they find themselves in a pit, a ditch, a deep ditch. A dark, deep ditch. It's so deep they can't see in front of themselves and they can't see behind themselves. They're trapped. They're scared. Then they look up and they see there's hope there. They see a tow truck coming and the driver is a psychiatrist. Imagine that, a tow truck with a psychiatrist driving it. The psychiatrist and the tow truck go to the patient, lift them out of the pit, take them and place them on the road. But when they land on the road, it's the patient that has to start up the car, put it in gear and step so that the patient goes. The psychiatrist cannot make the car go. The psychiatrist brings them and puts them on the road, but the patient has to step on the gas. Now in the front seat, the door opens in the front seat, and in climbs a psychotherapist, a therapist of some type. The therapist is there to help them start up the car. The therapist looks with them in the rearview mirror of where they've been and maybe understands how they got knocked off the road. But more importantly, they look at the front window, into the future, where they're going to go. They also prepare strategies to help them get around bumps along the road. In the back seat is where the minister is, the priest, the imam, the rabbis, the monks. Also in the back seat is your college professor. He's back there too. In fact, your grandmother's back there, your grandfather's back there. It's a crowded back seat. All these passengers in the back seat are there to inspire you, to influence you, to help you pick your destination of where you're going to go. They give you purpose, they give you passion, they give you meaning. The clearer and more distinct you are about where you're going, the better you can get through your emotional and psychiatric symptomatology. So the back seat is where people are who inspire you and influence you. They have profound effects on you. The front seat is where the patient sits together with a therapist who maps things out. The psychiatrist does many things, but mainly, I guess, is the tow truck operator. Now, if my mother heard me say that I was a tow truck operator, she'd say, "Why did we send you to medical school?" Patients in my career, there are a number of places of where church and clergy have had an impact. I want to introduce you to two of them. The first one's name is Robert. Robert's a man in his 50s. I've been seeing him for years, treating him for depression. He works at a construction company, and he works as the planner, kind of the sitting at the desk kind of planner kind of guy. He doesn't really like his job. He's been there 20 years. And unfortunately, the owners changed, and he doesn't like the owners. But you know, these days, when you're at a job for 20 years, and it pays you fairly well, in this economy, you don't quit the job. You stick with it. Robert's not married. He's not in a relationship. I've been seeing him for years, and I treat him for depression. I give him some antidepressants, but they don't work that great. One time saw a therapist for a few times, but that didn't really go anywhere. One morning I came in, and it was his routine visit, and he didn't show up. So at the end of the day, and that was unusual for him, so I called him at the end of the day, and I got his message machine that said he was out and he would call me back. He didn't, and a week later I called him again, and I got the same message that he was out and he'd call me again. A few months later, I called him again, and I got the message that said, "Your phone has been disconnected." So I thought, I've lost Robert after all these years. A few months later, I went into work, and my first patient appointment was Robert. I sat down with Robert and said, "Robert, I'm so glad to see you. I haven't seen you in months. You must be out of your antidepressants. What have you been doing?" Robert said, "Dr. Plovsky, to tell you the truth, I've never felt so well." "Robert, what did you do?" He said, "I did two things. The first thing I did is I quit my job. The second thing I did is I went with my minister and my church, and we went to South America on a mission to build churches. I like building churches. That's what I do for a living. I went and we built churches, and you know what? They liked me. They needed me. In fact, they asked me to come back in 6 months to build more churches." Now, speaking as Robert's psychiatrist, I really could have never told him to quit his job. And I know I couldn't have told him to go to South America to build churches. Somebody else had to do that, and they did. My other patient's name is Leo. Leo I've only seen one time, but he's coming back. Leo weighs 300 pounds. He's 6'5". He's a big man. He's diagnosed with paranoid schizophrenia. And when I met him, he told me that a year and a half earlier, he had been admitted and was in a psychiatric hospital. At that time, hearing voices, seeing visions, very delusional. He had a very, very bad crack cocaine habit. A bad crack cocaine habit. So I started off by saying to Leo, "How's the crack cocaine?" he looked at me in my eyes and he said, I don't do crack cocaine anymore. Crack cocaine is Satan. It's the devil's medicine. It's evil. It's Satan. They told me it's Satan and I don't do it. It's evil. So I said to him, okay. I said, what about the visions and the hearing of the voices? He said, well, they give me a shot. They give me a shot. They tell me it's the doctor gives it, but it's really God who gives me the shot. It's God's plan. God gives me the shot. So the voices are gone. I don't hear Satan's voices because God gives me the shot and I feel better and I don't do crack cocaine. So I was going to tell him how the effect of crack cocaine affects multiple neurotransmitters in your frontal lobe, and that the benefits of the antipsychotic medicines block the D2 receptors in your overactive mesolimbic area. But then I thought about it. And then I thought, nah, he's good with what he's doing. I'm good with what he's doing. And you're all good with what he's doing, aren't you? So, in conclusion, I think that the church and clergy are very important for us to continue to support, to continue to love, and to accept our patients without stigma. They're also very important to inspire and influence patients to help them find their specific destination of where they're going in life. I think they're also important that they have to distinguish when symptoms are pathological, persistent, psychiatric in nature, and could benefit from psychiatric treatment. They have to know when that is, and they have to know who to refer them to. But clergy also have to realize that very often they are the front line. But they must remember they're not in this mission alone. Thank you, and good morning.